I'm going to introduce our next speaker. The next talk will be by Rachel Miller. She's here today to share information on the best diet for neuroendocrine patients. Now, she's been working as part of a multidisciplinary team treating NETs, and that team includes Dr. Lowell Anthony, name you might know, and of course, Dr. Chauhan. She's worked at UK Markey since 2012, has been a registered dietitian since 2007. And with that, I'd like you to please welcome Rachel Miller.
Hi there.
Hello.
Thank you for having me, and thank you for the introduction. And I am going to try to provide some insight today on nutrition for neuroendocrine patients and help to maybe shed a little light for some of you. A few things I want to hit on today are what are our challenges with nutrition in neuroendocrine tumors, and how do we manage those symptoms? My kind of theme of the whole thing really is how do we individualize the diet? I have the pleasure of working with Dr. Anthony and Dr. Chauhan at Markey Cancer Center, and I have another dietitian that works alongside me. We see patients outpatient in all of our clinics, all oncology diagnosis, and I work exclusively with the neuroendocrine patients. We do nutrition therapy, counseling, education. We meet one-on-one. We meet with caregivers. And a lot of what we do is help manage some of those nutrition side effects of treatment, whatever that may be. We manage home nutrition, whether a patient may be home with a tube feeding, and also other conditions that may affect your nutrition in addition to an oncology diagnosis, diabetes, heart disease, kidney disease, etc. So we screen our patients and receive patients based on provider consults, but we are part of the team here, multidisciplinary and available for follow-up kind of as we see fit and really just kind of as the patient needs. So I think it's important to have someone in your area or with your team that you can reach out with to work closely with about nutrition and managing some of these things we're going to talk about. I bring up the importance of nutrition in cancer care because 40%, that's a big percentage of patients, oncology patients, do experience a weight loss prior to their diagnosis and or beginning treatment. This can be inclusive of neuroendocrine patients. And a little furthermore, 40 to 80% of oncology patients do experience some sort of malnutrition during treatment. When I say malnutrition, I'm talking about not only your intake, but also how it's going to affect your body and the outcome of your treatment, and weight loss, inability to really stay nourished. And the risk of that is reducing a dose of any type of treatment because of a major weight loss or inability to tolerate a drug because of increased toxicity. So we see some treatment interruptions, and so that's kind of where I want to intervene and prevent patients from getting to that point. You get to a kind of a vicious cycle of a weight loss and decreased performance status, which is ability even just to physically take care of yourself, to eat, to thrive, and sometimes that gets us to a reduced treatment response, and then we have decreased survival and decreased quality of life. So I want to get in there and individualize nutrition for my patients so that we don't have to deal with some of these things. I thought I'd talk a little bit about what I do when I see a patient here in our neuroendocrine clinic. For a lot of oncology patients, I'm looking at some of these things. But I do a little background information and reading. I want to look at your anthropometrics, and what those are is your height, your weight history. Have you had a weight change? What's your typical body weight, and what's the trend been for you in the past? I may look at your lab values. I know you all are familiar with tumor markers, those type of things, but when I look at laboratory values for nutrition, I look at hydration status and your electrolytes and what your protein stores might look like. So it can kind of give me an indication of what types of symptoms we might need to be managing. And then I may ask you about what your oral intake is. How is your appetite? How has it changed? And what percentage of your normal meal intake have you been able to consume? So we kind of know what we're up against. I do want to know your past medical history, so I can look at that a little bit before I meet with you, but I also discuss that with the patient. And so I can think about how that's going to affect how the patient is eating and what types of interventions we're going to be able to do. Um, Past surgical history is very important. A lot of neuroendocrine patients have had a bowel resection, not everyone, of course, but that's going to give me an idea of, and even just what type of bowel resection, what kinds of interventions we may need to make it to modify the diet. I'll look at your medication and treatment. I'll note which type of drugs that you are receiving or treatment specific to your diagnosis, whether you're on a somatostatin analog, and how is that affecting you? Where are you? Do you take a monthly injection and so on? Have you had chemotherapy, present chemotherapy, that type of thing? And of course, I'm going to ask you about your symptoms, and what particular side effects you may be experiencing presently, whether or not you have diarrhea or flushing, and nausea, vomiting, any of those things that are inhibiting you or keeping you from getting the nutrition that you need. So here's the challenges. Neuroendocrine cancer patients have very unique symptoms and side effects. So that's one challenge. And the other challenge with that is that the guidelines for nutrition are pretty general. We may have a set of guidelines that we kind of know, maybe foods that bother you, for example, but it's not always applicable to every patient. And one person may be able to tolerate something while another has a difficult time. Um, and the guidelines may not fit a person that has had a bowel resection. It may not fit a person that has had metastatic disease. Another challenge is specific types of nutrition deficiencies in patients with neuroendocrine tumors. Long story short, tryptophan is an amino acid, it's a building block of protein that is a precursor to niacin, and also, which is a B vitamin, and also to serotonin. And the neuroendocrine tumor, as you know, likes to use a lot of tryptophan to make a lot of serotonin. So if we're using a lot of tryptophan, we're not getting a lot of niacin or B3, and we can have a deficiency called pellagra, which is characterized by dermatitis, can also have some diarrhea associated with that, and also dementia. In other words, you feel terrible. Some trace elements, selenium, zinc, some of those may be affected by hydration status or malabsorption in the gut as a result of surgery. And so I'm looking at those things to make sure that we're on the right track and getting the nutrition that you need. So another challenge that I do want to talk about that I have found over the years working with a lot of my patients is that there's a lot of unnecessary restriction. So sometimes patients will present to me having not eaten a certain handful of foods for a couple of years, and but we don't really know why we're avoiding those. Maybe it's because they've been given a general list of foods, or some other research that family members with good intentions have presented, or other recommendations, or just kind of the kind of normal fear that you may eat something or do something wrong to hurt yourself. So that's very normal. So what I want to do is help you avoid that by individualizing, again, what we need to do for you, based on that nutrition assessment, based on your history. So the unnecessary restrictions are going to lead us to a limited variety of nutrients, not only the nutrients that you need, but also maybe you're not eating the foods that you like, that you're may even be able to tolerate, but you've just kind of eliminated them unnecessarily. And then if we're limiting our nutrients, we're probably also limiting calories and protein, incurring weight loss, and all of this combined is going to lead to a decreased quality of life. Um, and especially with how you feel and with your symptoms, and how we manage those is going to be important. So my goals, again, individualize, improve quality of life. This is going to be something that I focus on with all of my patients, because managing the symptoms can get us there, and coming up with a plan together will help. So diarrhea, everybody's familiar with that. Diarrhea in neuroendocrine patients is different. You guys know this. And it can be multifactorial in any patient. A lot of my oncology patients have diarrhea for several different reasons. But surgical resection, based on which parts of the digestive tract have been affected, are there mechanisms that are not functioning properly with enzyme delivery? Sometimes a pancreatic insufficiency where the patient is not digesting fats, and we do see some malabsorption with that, and that can affect your weight. It may be kind of hormone release related, bacteria overgrowth, and bile acid malabsorption as a result of or following a surgery. And the bile acids are released into the gut for digestion, but if they're not absorbed properly and at the right times back into the bloodstream as meant to, then we're going to have some diarrhea. And you may have heard the term secretory versus non-secretory, but secretory thinks secreting. So hormone release and some of the bile acid salts that are not being absorbed properly. But this is going to be, again, individual for everyone. Not everyone has had a bowel surgery, not everyone has a metastatic disease, or it could be something completely different. So that's another one of our challenges. So what do we do? You probably hear it all the time, but small, frequent meals are helpful. So we're not overwhelming the system. And I'm going to talk about fiber, but more what we call soluble fiber foods, which are more easily digested. And I'm going to tell you what that is. More soft and bland foods. Of course, you all have heard the brat diet. The things that are a bit, I tell my patients, you're being a little kind to your digestive tract. So things that are not heavily seasoned, foods that are easy to digest, and limiting some of the what we call typical aggravators, which in kind of regular diarrhea, if there is such a thing, these are true. But also for neuroendocrine patients, especially if they're having maybe a rougher day than another, high-fat, greasy foods, a lot of concentrated sweets, as far as sugary beverages, the volume of foods can affect diarrhea, and also insoluble fiber. So we're going back to fiber. I'm going to tell you what that is. Normal recommendation for anyone really is 25 to 35 grams a day, and a combination of both of these fibers. So I was saying the soluble fiber is more easily digested. It is the type of fiber that absorbs fluid in the GI tract to slow down the transit and helps to bulk the stool. Examples: applesauce, which has a substance called pectin, which kind of creates a gel-like situation in the gut and helps to kind of slow that down. Pears, bananas, banana flakes, which are an interesting thing, but they are something that can be added to other foods, so you don't have to sit down and eat a banana. You can mix banana flakes in with something that you're eating. Inside of a potato, and of course not the skin, because the skin is what we call an insoluble fiber. It does not break down by the body. And it's good to have that fiber because we do want transit and we do want gut health. But sometimes when you're having all that excess diarrhea, insoluble fiber is going to give you a problem, as I'm sure you all are aware. But that is the nuts and seeds, skins on fruits and vegetables, hulls, corn, peas, popcorn, that type of thing, and things that we may refer to as roughage and whole grains. I'm not saying don't have insoluble fiber because that's kind of the name of the game. I don't want to restrict if it's not necessary. So we have to see where you are, what your symptoms are, how many, what are you sensitive to? And then we'll move on to flushing and amines. Amines are naturally occurring substance in foods, specifically aged foods, and they become more concentrated. So the riper a banana is, the higher the amine content. These tyramine, dopamine, etc., those are types of amines. You may see those. But just to give you an idea, the amines are part of a chemical process in the body that creates what we call catecholamines. Long story short, it's epinephrine hormones that are released during the time of stress. So fight or flight type of deal. But neuroendocrine tumor likes to trigger this release in excess. We call this a vasoactive substance because that's what is affecting your blood pressure and your heart rate and making you flush and feel not good. I will say that the amount counts. So we have to look at how much of an amine food that a person may be eating. And again, just because you have this diagnosis doesn't mean that you have to stay away from these foods altogether. Just because you have this diagnosis doesn't mean that you have to follow a strict one-page yes, no, a diet. So to give you an idea, I know some of my patients are familiar with amine foods, and some have not heard of them before. Some are very sensitive, and some are not so sensitive. Some are sensitive at different points of time, so they may be able to tolerate some of these things in small amounts, and other times they may not. But the aged foods, the alcohol, the smoked and cured meats, some of these other fermented things can give patients a problem. A lot of times, some of these foods I have listed on this slide are not part of my patient's typical diet, so that's okay too. That's good. We go to more moderate amounts. Again, I show this to my patients to maybe help them associate what could be giving them a problem, so that you kind of can look at something and think, oh, I overdid it on guacamole. That's what happened. It's kind of it's unfortunately a trial and error. But my point is trying to help you get there with looking at all the information out there and finding which piece of it applies to you. Lower amine foods, the higher quantity of a lower amine food that you consume, the higher the amine content, and so probably the increase in symptoms. Foods that contain serotonin, tomatoes, bananas, avocados, 2 tomatoes. Yep, tomatoes. Tomatoes actually have been some of the things that unfortunately my patients have difficulty tolerating a lot, but some don't. Again, so I'm not going to tell you at all costs don't eat these foods, but we're going to look at things that bother you. So again, not necessary to avoid, except it can affect the urine level during the 5-HIAA testing. Okay, so what else do I have up my sleeve? I have been using an amino acid-based oral rehydration solution called Dietary, and what that means is it's an amino acid blend. Amino acid are pieces of proteins. There are several of them. But this particular blend is designed to help tighten the gut barrier, possibly rebuild that villi, which is those microscopic little finger-like things in the lining of the gut that facilitate absorption and at the proper time. And so we look at this as helping the gut absorb nutrients, stay hydrated, decrease the frequency of diarrhea, and also really help improve with improvement of diarrhea, cramping, bloating, some of those uncomfortable symptoms. We have been for a few years using this with a lot of our patients and did a retrospective study with the team to really find that a large number of our patients reported some type of improvement, whether that was a decrease in diarrhea, whether it was improvement in energy or hydration, nausea, and a good 51% reported more than 50% reduction in how many times a day that they had to use the bathroom. So I've had a lot of patients tell me they've been able to even tolerate more foods that they had not been able to in the past. Um, so it's a lot of times worth a try, and really an easy thing to try because it's not a medication, it's not another pill. It's not a supplement. It's not an electrolyte replacement or anything like that. It kind of helps your body maintain its electrolyte balance and absorb nutrients more properly. It's kind of how I describe it to my patients. And it can be used as needed. So it's not something that you have to use every day, all the time. We can kind of tweak the schedule based on how you feel it works the best for you. So, and we're not changing anything else. It's really just an addition to all the other standard of care therapy that you may be taking, including anti-diarrhea medication. There is no sugar content, so we are avoiding some other unnecessary secretion. Like I was talking about, high sugar content of foods and drinks can exacerbate diarrhea as well. So that's another point about the product. If it's something that you're thinking about trying or have more questions about, definitely talk to your dietitian and your physician about it. I think it's been very beneficial for a lot of our patients. So overall, my recommendations: smaller, more frequent meals, balanced meals, plenty of protein, where we have a lot of that increased use of tryptophan. We want to make sure that we have an adequate protein store, and that just helps really with energy and nutrition status. Focus on some of that soluble fiber that I mentioned that is going to be more easily digested, and we're going to individualize. It's about you. It's about, we have lots of patients. They may have the same diagnosis, but they may not have all the other factors and all the other experience that you have. So I want to liberalize the diet. Sometimes I say we just start from scratch. We're going to look at everything and start over and figure it out. So I do encourage to write down what you're eating, however you want to, if you want to do it electronically, or pen and paper. And even I tell my patients, you don't even have to show me, but I think it may help you to look at and visualize what time of day, when was my injection, where was I, what was I eating, how much did I eat, and what were the symptoms. So you can kind of associate what things may be giving you a problem. Generally healthy diet, of course, that's typically going to be low in fat anyway, have a good amount of protein and carbohydrates. Of course, it limits processed meats, foods, alcohol, added sugars. All those things that can exacerbate symptoms anyway and really not give us a lot of nutritional benefit. And then see if we need to correct any nutritional deficiencies. It just depends. Not all patients may have a niacin deficiency or tryptophan deficiency, or any other type of vitamin or mineral deficiency. I do encourage nutrition from food, because your body really knows what to do with that. And I based some of my recommendations in my model on the New American Plate, from the American Institute of Cancer Research. balancing your meals, fruits and vegetables, whole grains, and we can find which fruits and vegetables and whole grains and protein foods that work for each patient. So I ask you to think about maybe where do your symptoms fit into all these general guidelines and all these no's. So how do you tolerate these foods? There's not any one thing that I'm gonna say absolutely stay away from. We want to see what works best for you because I want you to be nourished and I want you to have a quality of life, not have to focus on food so much because you have other things that are so important to spend energy on and not be concerned about, and want you to be able to enjoy food and as well as your life. So thanks for having me. I hope that I was any help to you all and informative. And this is my email address. If anybody has any other questions they think of later on, I'm happy to talk with you.